To present this session, we have an eminent speaker with us, Professor Dr. Anirban Mazumdar, attached with KPC Medical College and Hospital. And to chair this particular session, I'd like to invite Dr. Ridish Narayan Chakraborty, consultant physician and endocrinologist attached to Narayana Hospital, and Dr. Shoiban Chakraborty, consultant physician and dermatologist attached to GD Hospital. I would like to request both the chairperson to introduce our speaker.
Hello. So though in mythology we talk of Ardhanarishwar, and at large in the society we are having a binary of males and females. But if you dissect into the matter, you can find many shades of gender. And for that we have an exciting topic and an eloquent speaker. And Dr. Shoibal Chakraborty will introduce our speaker.
I dare say I can introduce Dr. Anirban Mazumdar, who is a very eminent speaker of our city in endocrinology field. And it's a pleasure because the subject he will speak on, I have been goading him to write a book on because he has covered it so nicely. There is an exciting book called 50 Shades of Grey, but I think his 50 Shades of Gender will be even more exciting, and particularly for the lay person, because we might not know the chromosomal, but we can enjoy, as he was alluding. Transgender has been in our classical literature. Dr. Anirban Mazumdar is Professor of Endocrinology at KPC Medical College and very close to our heart, and an erudite speaker. I have heard him speak on this subject and he will do great justice to this. I have no doubt about that.
Thank you, Shabalda. I think, am I audible? Is this working? Okay. Okay. Thank you very much. So, I think that we must know a little bit about the gender. Can you please close the door? So, it is working? Hello? 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 So I am actually standing between you and the lunch, so we are already running late. So I think we must know a little bit about the gender, because now our society is progressively improving as far as looking into the different gender varieties and the gender diverse people. So I will talk on those gender diverse people in my topic. So I'll go through these agendas, and especially I'll talk about the important aspect that why all the physicians should know about this gender issue, because there are a lot of health risks associated with the people who are gender diverse. So first we have to start from the basics, that the basic understanding between the gender and the sex. Now the gender and the sex is not the same thing. If you look into the World Health Organization definition, the sex is basically assigned. So all of us, we are sitting in this room, our sex has been assigned by somebody else, and we did not have any say as far as our sex is concerned, whether you are male or female. So sex is assigned by the doctor, by the nurses, by the physicians, by the parents, by the family members. But on the other hand, if you look into the gender is basically evolves over time. So gender is something different than what we talk about the sex. So sex is assigned, gender evolves with time, and basically it constructed with many characteristics of men and women, and it also depends on many other factors. That means the environment has got a very, very important role as far as the gender is concerned. However, in most of the situation, the assigned sex and the gender is in the same line, or the assigned sex and the gender is basically same to almost all of us. However, there are some situation when you will find only a small fraction of the patient, those whose sex is not corresponding to the gender of the person. So I am going to talk about those people whose sex and gender are basically different. So any people who do not fall into the category of the traditional understanding of male and female. They belongs to this group. That means they are gender non-binary, or we can say gender queer. Now let me take you through one or two examples that how the sex and the gender differs. Now you can see that this is a 16-year-old female who has a primary amenorrhea. There is a small lump in the labia, and you can see that the patient is basically phenotypically completely female. So, but one of the very, very important clinical sign is that the patient had no axillary on pubic hair. So we have done the karyotyping. It was 46XY, and then the lump was operated. We have taken out the another gonad also, and it was found that the patient is actually having testicular tissue, and this is a case of complete testicular feminization syndrome. Now what I mean to say that just you look into the phenotypic of this person, phenotypically female, but if you look into the karyotyping, it is XY. It means that there is a significant dichotomy as far as the phenotypical sex and the chromosomal sex is concerned. So just to impress you, this always does not match. Now let me take you through this another important example. This is one of the patient who came to our OPD in the long back, and just looking into the person, I thought that the person is not looking like a woman. So I asked this person to undress, and you can find this is a completely male subject. So this patient has got definitely the biological sex was male, because at the time of birth he was assigned male sex. However, if you look into the person presentation, so I say that that is known as gender expression. So gender expression is female. So it means that the biological sex and the gender expression are sometimes different. The way we are born and the way we would like to present ourselves, there may be some difference, and that needs to be understood. So first, if you look into this example, this patient has got presented with a biological sex of male, and at the same time the patient has presented with a gender expression as female. However, between the two, there is something in between, and that we call is psychological sex, or the identity which resides inside the brain. So therefore, one is biological sex, that means with which you were born. Second is your identity, which is inside the brain, what I feel about myself. And third is how I express myself, that is gender expression. Apart from these three important dimensions of gender, we have a fourth dimension, what we call is sexual or romantic attraction. So it is also called a orientation. So what is sexual orientation? Orientation is the attraction. In most of the situation, our attraction is towards the opposite sex or opposite gender, but sometimes the attraction may be towards the same sex, maybe towards the both sex, maybe towards the none. So there is a lot of permutation and combination is available, and that is known as orientation. So when we are talking about the sex and gender, it means there are four important dimensions which we are talking about. One is sex, which varies from male to female, and then we have the identity, that is the gender identity, which again from man to woman there are many shades available. We have gender expression, and lastly is the orientation, what is our attraction. On the right hand corner, you can see this is the cisgender heterosexual woman, means the person is basically female and has got the attraction towards the men. And on the left side panel is basically cisgender heterosexual man, and the person is basically man, biological sex is man, and the patient has got an attraction towards the woman. However, in between the two, there are a lot of shades, and there are a lot of option or lot of permutation combination is available, possible in our clinical picture. Now let me talk about my experience, but before I talk about my experience, let me understand that the most important group of people among this set of gender queer family. Now this is normal. That means a person has got a assigned sex at birth is male on the right side, on the left side, and then the patient has got a chromosomal sex XY, gonadal sex testis, phenotypical sex male, and gender identity is also male gender role, and we call it man. On the other hand, just opposite, we call it as female. So there are basically, if we look into, there is a chromosomal sex, there is a gonadal sex, there is a phenotypical sex, and there is a gender identity. However, this is quite matching. They corresponds, the assigned sex at birth corresponds with that of the chromosomal sex, gonadal sex, phenotypical sex, and identity. But sometimes it may happen that the assigned sex at birth may not match, or the gonad may not match, or the chromosomal sex may not match. And in this particular case, if there is a no matching with the identity or the psychological sex, then we call it trans people. So there may be transgender woman and there may be transgender man. So this group of people whom we are talking about, it was initially termed as gender identity disorder as far as this DSM-4 criteria. Later people thought that it should not be said as a disorder, so they came out with the new definition or new terminology as gender dysphoria. Now very recently in 2018, World Health Organization has said that that is not a disorder. It should not be discussed under the heading of mental and behavioral disorders. And then we come to know that we should call them as a gender incongruence. So it should not be a disorder, it should not be dysphoria, but just an incongruence. Now if you look into this young person, actually has got a significant desire to become a woman. So we have started the hormonal therapy, and he underwent through the gender assignment surgery, and this is trans feminine. Just the opposite can happen. This is a woman who actually wanted to become a man and underwent through the testosterone therapy as well as the surgery. So we call them trans masculine. Now this is a young boy who came to me in 2001 with the puberty gynecomastia, and you can see that his parents were quite apprehensive about this gynecomastia, but he was not much apprehensive. But somehow he came back to lost in follow-up after 2001, came back in 2010 when I found that the gynecomastia was still present, and he was quite depressed and he has got suicidal thoughts. So we asked for the psychological checkup, and we diagnosed this patient as a gender identity disorder. We started the hormone therapy, and in 2013, after the hormone therapy and the sex reassignment surgery, you can see that she is sitting with a very confident posture in the examination couch. So after hormone therapy, now we have published our 55 transgender subjects and our experience, and we also have published the consensus statement on the management of the people, those who seek gender reaffirmation as female. Now this is another young woman of 20 years who was biologically female, but she wanted to be a man. So we started the testosterone therapy and became ready for the sex reassignment surgery after 2 months of the hormone therapy. And then you came in the follow-up after the sex reassignment surgery with his partner at the age of 22. That is very, very important, as far as the success of the treatment is concerned. So this girl became a man and came with a partner at the time of examination. So we published our experience of 18 transgender subjects, and we also published the consensus statement for the people who are seeking gender affirmation as male. And nowadays in our clinic we have roughly around 400 patients as far as the transgender people is concerned. Now apart from this transgender group, as I've told you, the gender this gender issue, or there are a lot of shades, 50 shades. So there are a lot of shades as far as gender is concerned. So you can see this is one of our patient who, a student of comparative literature, she assigned female sex at birth, sexual orientation is female, but mentally and physically attracted to another female, and she is not interested to change her gender. She had lots of anxiety, thought herself alone and insecure. This is a young 20 years aged person who was student of commerce, And he said that I am a gay, assigned male sex at birth, sexual orientation male, mentally attracted to male, disliked interacting with women. His mother was quite worried, and he had no anxiety but a huge challenge for his parents. This is another man of 20 years. He has a tendency to talk excessively, woman-like behavior, woman-like walking and gesture, physically attracted to female. His mother worried about the hormone defect and asked me, doctor, you give him some male hormone because he lacks the male hormone. Give male hormone and he should become like a man. And he was bullied by many peers since adolescence for female mannerism, not interested to change his gender. 2 suicidal attempts, hanging. He tried to hang himself for twice. And this is an important challenge in front of us. This is another young girl of 26 years. She was diagnosed as congenital adrenal hyperplasia with salt wasting with crisis at 10-day age, karyotype 46XX. Clitoroplasty done at the age of 2 years, reared as a girl, spontaneous puberty at 12 years. But now she desires to become a male and adopt a male typical behavior. That raises a very, very important question in front of us, that what we are doing with the people with congenital adrenal hyperplasia. So should we rear them as a male? So that's an important question in front of us, and we don't know the answer to this question. Now this is 2 young people, and you can see on the right side is basically a girl who wants to become a male subject, and the left side is basically a young man who wants to become a woman, and they used to come in our clinic, and they fell in love while coming in our clinic, and you can understand that the number one, this is a biological sex is female on the right side. Biological sex is female, gender identity is manness, romantically attracted towards femininity and not towards a girl. Attracted towards femininity, not towards a girl. And on the other hand, this is a biological sex is male, gender identity womanness, and romantically attracted to masculinity and not towards man. So the another example, this is a very, very interesting example. And you can see this is the person has got a biological sex is male, gender identity womanness, romantically attracted to female, but he said that I do not want to undergo sex reassignment surgery, but I want the female hormone to develop my breast and hair. I should look like a female, but I do not want to go for gender reassignment surgery because I do not want to remove my testes and the penis as well. On the other hand, his partner is another girl, and the biological sex is female, gender identity is womanness, romantically attracted. I asked, why you are a woman wants to have a relationship with another girl? She said, no, I am basically woman, but I have attraction towards both sex, so I am a bisexual. So this is and this is another 23 years old man, came only few days back to me, and he's a student of master degree, very quiet, shy and distressed, suicidal thoughts, dysphoria from beard and mustache. The only problem is with the beard and mustache, uses razor 2 to 3 times daily to remove them, and no attraction towards men or women, not attracted to anybody, and not interested to develop breast, are not interested to change the gender, but he wants no beard, and that is what he wants to develop himself. This is another 32-year-old someone from Bangladesh, consulted our endocrine clinic for female hormone therapy. She ran away from her family at the age of 16, joined a Hijra community, underwent castration 14 years ago by quack inside the Hijra community quarter in a remote village of Bihar. And you can see that the surgery, and you can see that has actually is basically neither male nor female as far as this surgery is concerned. It was basically not surgery, it was done by a quack, just remove the gonads and the penis. So we have very recently we have reported the 3 cases, though there are a lot of Hijra we see, and almost all of them has this kind of external genitalia. Neither they are neither male nor female. Now if you ask this question, how do you describe your gender? I know invariably almost all of you will say very directly about your gender, but if we ask the same question to some of the people, they will not give a very straightforward answer. They don't know what is their gender. So that is an invariable issue as far as some of the people across this world, and it is as varied as people cannot tell just from looking. It is complicated to figure out, and the best way to understand, you ask him, what is your gender? And that is the way by which you can understand that what gender he or she belongs to. So if we ask this question that how many types of gender we have, yes, on one hand we have the man, on the opposite side we have the woman. If we think about the binary way into the gender issue across the whole population, but in between the two we have the trans-masculine and trans-feminine. Yes, even if we are thinking about trans-masculine and trans-feminine, you are actually thinking about binary issue as far as the whole gender issue across the world is concerned, and you are leaving behind those who are not actually binary. So all those who are non-binary are kept in one group, and they are roughly around 0.6% across the world. We don't have data from India, but this is something we have got some prevalence data from other part of this world. And if you consider this 0.3% also, then in India we have roughly around 50 lakh this third gender community people in our country. So if we think about the third gender issue, third gender was not that it is something developed and coming to us very new. It is there since the ancient time, and it was there in our literature, it was there in our mythology, it was there in the scripture, in the sculpture. So not only on this part of the world, but this third gender was actually was quite well known to the Western world as well. As you can see, this is a Greek marble from the 2nd century BC, and I have personally gone to the Louvre Museum to see this sculpture, and you can see this sculpture. This has got both penis and the breast on the same sculpture. So this indicates that this idea and concepts were there not today, but a few thousand years of our history, and you must have seen them. This is people from the Hijra community, and if you look into the third gender in our country or across the world, we call them as a gender queer or the rainbow community. And anybody who is not heterosexual and who is not cisgender, we consider it under the heading of the third gender community. And Hijra is basically the largest group, one of the largest group, and officially recognized third gender community in our country. Apart from them, we have the intersex disorder and transvestite in the group. And you must have heard this LGBT community, the lesbian, gay, bisexual and transgender. So they are also in the third gender community. Among them, the transgender has got the maximum prevalence. Apart from this, we have the two-spirited, we have asexual, we have ally, and we have bigender, who actually moves between feminine and masculine gender in the same life. And also we have some people who do not know about their gender, that we cannot classify them under any of the heading what is known to us, and we put them under the heading of questioning or the queer. And lastly, let me talk about how we look into the gender issue. As I've told you, the first thing we should look into the phenotypical characteristic, and that is the biological sex. The second thing, we should look into the identity that resides inside the brain and not in the perineum. That what we feel ourselves, that is inside our brain. And third thing is what is our attraction. It may be sexual, it may be romantic, or both. And lastly, how we want to express ourselves to the community or to the other people. So the biological sex, gender identity, attraction, and gender expression, all these four are very, very important issue as far as gender is concerned. And apart from the male and female identity, lot of permutation combinations is available in between the two. So when we place them, it basically there are a lot of shades. On the two end, we have straight men and straight female. In between, we have gay, bisexual male, trans masculine, asexual male, questioning, asexual female, trans feminine, bisexual female, as well as lesbian. So why we should know about them being as an physician? Because of the fact that there are a lot of health risks as far as these people are concerned. The most important health risk, if we look into the data available to us across the world, is the psychological risk, and second is the substance use disorder. So every individual who are basically belongs to this gender queer community should undergo a mental health evaluation, and they should be screened for the substance abuse. That is a very, very important issue among these people. Very recently, we have looked into our data as far as how many percentage of the people has got the addiction issue. We have published in 2 years back among 120 of the transgender community, and we have found that the 50% of them has got some degree of addiction, some smoking and alcohol, but very, very importantly, we have not found anybody who is actually marijuana addicted or intravenous drug addicted. So that is a sharp contrast to the Western literature, where it has shown that there are a lot of marijuana and intravenous drug abusers in the transsexual community. So suicidal thoughts is one of the another second most or very important health risk factor among the transgender community, and this is an review article which was published, which showed roughly around 50% people of transgender community has got suicidal thought and suicidal behavioral. And if we look into the transgender adolescent, it is very, very pity to understand that 50% of the male to female adolescents actually undergo, so female to male adolescents undergo some degree of suicidal behavior. So that is very, very frightening, and we have found very, very little literature in our country. Only one publication available to us, published in 2016, has highlighted roughly suicidal attempts in 30% of the transgender community, with 15% have got the first suicidal attempt at the before the 20th birthday. That is the very important. And we have very recently published our data also, and you can see that the first attempt of suicide is around the age of 16 years. So that is also very, very frightening. So I would like to take to my last part of the talk, that is my take-home message, that we have roughly around 1 lakh type 1 diabetic subjects, but if you look into the 2011 census, we have 5 lakh transgender people. But the most of the physicians know little bit about the type 1 diabetes, but the people are not aware much about the transgender community. And very recently, the Chief Justice of India said that the criminalizing homosexuality is one of the many injustices. However, the India government has opposed recognizing the same-sex marriage, but the Supreme Court has set up a 5-judge bench which will look into the plea of the square marriage in India, and the decision will come by this month of October 23, for which we are eagerly waiting for. We have seen lot of media, lot of movies on this transgender community. We have Aligarh 2016, the Janana 2016, Nagar Kirtan Tali very recently came with, starring with Sushmita Sen, who played the role of Gauri Sawant, who is an LGBT activist, and she actually led the full LGBT community to have the adoption rights for the transgender people. So my take-home message is that non-binary gender queer identities should be recognized by the healthcare service system, and treatment is available to assist people with gender dysphoria and to find a gender role that is comfortable for them. And third is creating welcoming clinical environment, not only for the trans community, but also for the non-gender queer people, to disseminate right information and reduce the healthcare risk. I conclude by taking a small, quoting a small poem from Tagore, Aro alo, ei noyone prabhu dhalo. Thank you very much.
I think it's a very, very lucid talk on a very, very complex subject. Perhaps we have understood a little bit, and we are all in pink of health and not think about suicide. It's pre-lunch. I think we should think it as an oration and not invite any question. But Anirban will be happy to answer any and every question that you have.
First of all, I just had a small question. This is a fantastic topic. The gender identity, which resides more in the brain. So my question is, those people who do not have any genital ambiguity,
Yep.
those patients, when they are having some incongruous feeling, that is genitals male but thinking I am a female inside, trapped in a male's body. So does this thought come intrauterine, or it may be due to some factors outside when they have come in this world? This
This is, I know you are asking that the etiology of the disorder. Now, you know that if you look into the trans community, only a very, very small fraction of the patient has got intersex disorder. Don't think that they have intersex disorder. Almost all of them are either man or woman as far as the sex is concerned, means the biological sex is concerned. Now, why they have developed this idea? If you ask this question, my straightforward, very direct answer is, I don't know. This is the first answer. But if we look into the why, there is a lot of supportive data and evidences which suggest that some traumatizing sexual behavior at a very tender age. This is the environmental factor which may make someone as cross-gender identification. This is one very, very important etiology people describe. Second is any kind of androgenic exposure in the intrauterine life, that we have to understand that the genitalia develops in the first 3 months of the intrauterine life. So first 3 months is the period of not genitalia but every organ development. Now the brain development continues. Brain development even continues after birth, so up to 6 months. So that is why any influence which is happening in the second trimester or third trimester can change the gender behavior. If the brain is exposed to slightly higher level of testosterone in the later part of the pregnancy, when the genitalia has developed, because in the first trimester genitalia has already developed, but the brain has exposed to androgen, and that is why the congenital adrenal hyperplasia people has got this one. And third important explanation is the endocrine disruptor. So because lot of endocrine disruptor, the mother is almost exposed to 500 endocrine disruptor even today, to every mother. So this is also has got a invariable impact, and people feel that lot of endocrine abnormalities, especially the trans issues, is going up and up just because of the endocrine disruptors during pregnancy.
Thank you, sir. That brought a lot of clarity. Thank you.
Sir, castration before puberty, particularly in the males, does it have any effect on the gender identity?
What you said?
Castration before puberty, like done in Hijra community. Castration before puberty.
Castration before puberty.
In Hijra community.
Yes, that is basically the way it is started from Ottoman Empire. From Ottoman Empire, it has been started to castrating the male child, and they used to take them as a khoja to protect the harem, because if they are castrated, they have no sexual function. So that whether that can cause transgender issue or not, I don't know. But in the Hijra community, they have the tradition to castrate to make them as a member of the community. So that tradition is there. And this tradition, if you look back, that is from the Ottoman Empire, it has been started to protect their harem. But one is that in the pre-pubertal period you are castrating. So the gender has not yet developed. Their sex has been assigned, but whether that can lead to transgender ideation or not is not known to me.
Dr. Mazumdar, what do you mean by the term endocrine disruptors? What do you mean by those things?
So endocrine disruptor, again, it is again a big issue. Now endocrine disruptor, where it is not there, just tell. The shirt you are wearing and their color, it has got an endocrine disruptor. The water you are drinking from the plastic bottle, there is an endocrine disruptor. Endocrine disruptor is there in the fertilizer, endocrine disruptor is there in any color. So if you take any colored food, artificially colored food, not naturally colored food, they contain the endocrine disruptor.
You mean to say the food adulterants or the food additives?
Huh?
You mean to say the food adulterants or the food additives?
No,
or the different
not food
flavors
additive.
which you add?
Food additive is different. Endocrine disruptor is different. Say the people are wearing the lipstick that contain endocrine disruptor. In the perfume, there is an endocrine disruptor. This is not entering into our body in micro quantity. They are entering into the body in the nano quantity. But you are constantly exposed to so many endocrine disruptor and nano quantity is entering in your body, and that actually impact, because endocrine disruptor has got 4 important impact. Number 1, either they are estrogenic or anti-estrogenic, they are androgenic or anti-androgenic. So these are 4 important endocrine impact, and that actually leads to many important diseases. One is infertility, second is your any sexual related issues, third is your metabolic disease and diabetes, and fourth is cancer.
At which level do they cause a disruption? At which level?
No, I don't know any level, but if you look into there is a website called TEDx, and if you look into the TEDx, there are 1400 items are there which are endocrine disruptor. They have closed this website, but the website is alive. They are not adding a new endocrine disruptor because they have found endocrine disruptor is in almost all artificially produced items.
Thank
but
you.
I don't know any level.
One last question. I was thinking, we have seen many celebrities having this problem. Now, are people with high level of IQ or cognitive superiority more prone to have such things?
No, I don't know any data regarding this, but I don't think Hijra people has got a very high level of IQ. So, I don't know whether it has got any impact or not.
Thank you, speaker. It's time to felicitate him.